Amy, Amy, you think I can use both of these together? Should be okay. If you want to take your seats, please. Did all of you get a chance to go over the CPC, the 5 cases I sent? Yes? Okay. So a 65-year-old non-smoker presents to her dentist with these lesions. The dentist refers her to a periodontist because they did not know what was going on. So what do you think is the most likely diagnosis here? What's going on here? White and red patches, okay. Leukoplakia, okay. Anyone? Any other volunteers? Leukoplakia. Isn't that PVL? So why do you say that, Alicia? She's older. And what do you see here? Multiple sites. That's why it's PVL. So leukoplakia, okay, but here we are talking of a more high risk variant of leukoplakia. This is a non-smoker female, older female, but you see that multiple sites of involvement. If it was localized to just one area, then I would say, okay, maybe leukoplakia, but this is proliferative verrucous leukoplakia. Give 3 differential diagnoses for this pigmented lesion on the palate. Graphite tattoo, amalgam tattoo, so what do you have on your diagnosis? If most of you or all of you did, look at the cases, did you write the diagnosis? Justin? Melanotic macule, yes, it can be. Abby? Now I recognize you. So what color? What color is it? Yeah. Anything in the melanin family that you can think of? So we came up with melanotic macule, amalgam tattoo, maybe graphite tattoo. Can you think of anything else? Melanocytic nevus, right? If we are talking of the benign and reactive ones, then you can also throw in a melanocytic nevus. What is the most likely diagnosis for this diabetic patient who presented with widespread white lesions and they look like this? Pseudomembranous candidiasis, very good. So more diffuse, generalized white lesions, and I may give you a clue that they are wipeable. Pseudomembranous candidiasis. Okay, give 3 differentials for this ulcerated lesion on the ventral tongue, and this is the one. Squamous cell carcinoma. And why do you think so, Justin? It is ulcerated, and common site. Okay. Oral hairy tongue leukoplakia. So there's a oral hairy tongue and there's a oral hairy leukoplakia. Which of the two are you talking about? Oral hairy leukoplakia. But you also see there's an ulcer here in the center, right? And I did write this ulcerated tongue lesion. Do you think oral hairy leukoplakias present as ulcers or just as white lesions? That's why we will not put that on the list. Anyone? Like a traumatic ulcer? It can be a traumatic ulcer. But I think what stands out in this picture, if you see closely, look at the borders around the ulcer. What do they look like? Hmm? Ruffled, they are raised, right? So raised, kind of rolled, and it's okay because I don't expect you to identify, squamous cell carcinomas right away, but I'm just showing you some helpful hints that may put a cancer on your list. So a central ulcerated lesion, but the borders look somewhat raised, right? If it is a traumatic ulcer, you don't see those kind of borders. They will be more like flat, the same level as the rest of the mucosa. But here you see raised, somewhat rolled, and if I asked you to feel it, palpate it, it will be firm. The borders will be firm, and that's what we call induration. So raised rolled borders with an ulcer and induration is highly suggestive of cancer. Now, such kind of presentation may also be seen with some other entities, but definitely you should have oral cancer on the top of the list and you want to rule out. So immediately do a biopsy or send the patient for a biopsy. Other lesions, okay, like we talked about, could this be a traumatic ulcer for you guys? Yes, I will put it on the list. But if it was a D4 student working with me, I will not accept that. Traumatic ulcer, squamous cell carcinoma, or maybe a precancer, or you can say you do see white areas, you see red areas. Could this be erythroleukoplakia presenting with an ulcer? Or in one of the lectures, I remember I gave you a slide where there was an ulcer on the lateral border of the tongue, and I gave you a list of different entities. It can be from a deep fungal infection, for example, disseminated or more generalized histoplasmosis, blastomycosis. Those kind of infections can result in ulcers in the mouth that can look somewhat like this. Okay. And the last one, a 30-year-old male presents for prophy, and you notice this lesion. There were no other lesions. So what do you think is going on? Do you have a diagnosis or a differential diagnosis? Yes. Tobacco pouch keratosis. Any other answers? Candidiasis and leukoedema. And what makes you think of that? Okay. So what is your diagnosis? If I give you this on the exam, I will not ask you for a differential diagnosis because it's quite obvious from the picture that this looks like some smokeless tobacco use, tobacco pouch keratosis. I will ask you what is the most likely diagnosis. And if this is something that you may have different options, like I show you a white lesion on the tongue and I ask you, give me a list of 3 differential diagnoses, because you never know unless you biopsy what that white lesion is. So in that case, I will ask for a list of differential diagnoses. But the pictures that are very obvious, you can clinically make a diagnosis. I will ask you, what do you think is the diagnosis, or what is the most likely diagnosis? So just write one diagnosis if I ask you for most likely diagnosis. If you give me 3 diagnoses, you will be graded on the first one. I will ignore the other 2. Okay? Any questions on the CPC? And I can give you one more CPC to work on before the midterm, so you know what kind of clinical questions like picture based you can expect on the midterm. Okay, and let's do the review session. Do you need some time to log in? So there. How do I make you to see all of the options together? Present, maybe? The most common type of oral melanoma is I will wait for at least 40 responses before I move on. So it's up to you now. The most common type of melanoma the right answer is acral lentiginous. So the most common type of cutaneous melanoma is superficial spreading, whereas the most common type of oral melanoma is the acral lentiginous. So this is the one that the patients often have, on the hands, on the palms, soles of the feet, under the nails, subungual, and in the oral cavity. Which of the following is caused by Epstein-Barr virus? And if you don't know the answer, just throw a wild guess. So 49% said oral hairy leukoplakia, some said hairy tongue, 39% lichen planus. So what causes melanoma? Epstein-Barr virus? No. Acute sun exposure. And what do you think causes oral melanoma? Acute sun exposure? Then what causes oral melanoma? Genetic mutations. Okay. The second option is oral hairy leukoplakia, and that is the right answer. Hairy tongue. What causes hairy tongue? When there is not adequate, desquamation, clearing of the cellular debris, or patient has poor oral hygiene, they are chronic smokers, they have dry mouth, so saliva helps to clean the oral cavity, right? So when a patient has dry mouth, that's another factor that can contribute to hairy tongue. Or a patient has had head and neck radiation, which causes dry mouth, or they are on any medication. So what causes lichen planus? Epstein-Barr virus? So what kind of condition is lichen planus? It's an autoimmune condition. So the patient's body, a patient starts producing autoantibodies, which means the system produces antibodies that target the host's tissues. So patient's body attacking their own tissue. So lichen planus is a chronic autoimmune condition. The right answer is oral hairy leukoplakia. Many times patients who have AIDS or immune suppression, that's when Epstein-Barr virus can, become active, and they can cause secondary infections, one of them being oral hairy leukoplakia. These are representative of So let's look at the responses. We have 3% said lipoma, 10% xanthoma, 88% granules. So the right answer is Fortis granules. And why not lipoma? Why do you think this cannot be a lipoma? Usually they are solitary lesions. You see a cluster of white, yellowish, kind of small tiny papules that are coalescing together forming a cluster. This is a very common condition you will see in the patients. These are Fortis granules, so they are ectopic sebaceous glands in the mouth. Sebaceous glands are not meant to be in other places other than the skin, but when you see them in other sites, they are called ectopic sebaceous glands. Exfoliative cytology is useful for. So there are 5 options. Okay. So this is from today's lecture. And that tells me many of you did not pay attention to what I said. All of the above. So all of the above means candidiasis, herpes, dysplasia. The right answer is 2 of the above, candidiasis and herpes. And why do we think dysplasia is not? Yes. Very good. So it's a cytology like a smear. The brush cannot reach to the basal cells where dysplasia starts. Okay, that's why it's not a good technique for diagnosing dysplasia. It's a good technique for, say, any fungal infection, any herpetic ulcer that the patient may have. Which of the following can have irregular and ill-defined borders? It said malignant lesions, then 93% two of the above. The right answer is two of the above, and the two are malignant lesions and inflammatory lesions. They can both have ill defined, not so well demarcated, irregular margins. So encapsulated, so if you see all of the above, it does not mean that that will be the right answer. I can trick you anytime. Be careful. And sometimes I intentionally throw that all of the above. Let me see if they got it or not. Because when you think that this will be the right answer, no, it may not be. So encapsulated lesions, encapsulated lesion means that it has a capsule around. Unless that, if it is a malignancy, inflammation, unless it infiltrates and comes out of the capsule, you will not see ill-defined margins. That's why it remains within the capsule. They will look more like well-demarcated lesions. So the right answer is malignant and inflammatory. Which of the following are implicated in squamous papilloma? And you can go back and look into your lectures if you want. This is not a test, so feel free to do anything. Okay, we got 41. So 5%, 2 and 4, 73, 6 and 11, 13, 32, 12, 13. So one person said, okay. The right answer is 6 and 11. HPV 2 and 4. So HPV 2 in verruca vulgaris. 4 is just made up. 6 and 11, the right answer. 13, 32 in Heck disease. 12, 13, I just made it up. Okay. Moderate dysplasia refers to atypical changes that are confined to. Lower 1/3, middle 1/3, upper 1/3. Okay, no one picked all of the above this time. The right answer is middle 1/3. So mild, lower 1/3, moderate, middle 1/3, and severe, upper 1/3. Extending all the way to the upper 1/3. Remember it this way. Mild, moderate, severe, lower, middle, upper. Okay. And what is the treatment for moderate dysplasia? How do we treat mild dysplasia and moderate dysplasia and severe dysplasia? Mild dysplasia? Hmm? You want to watch or you want to excise? Watch. And moderate and severe, you want to excise, right? Moderate and severe, higher chances of turning into malignancy. Some people like to excise mild dysplasias also, it's your call, but if you can follow up with the patient every 6 months and you don't notice any change in the pattern and the way it looks like, then you can keep watching for some time. Which of the following sites have a worse prognosis for melanoma? See, don't look at what others are doing. Okay. So which of the following have a worse prognosis? Remember, what are the 4 sites? So one said arm, one said scalp, 11 back. So here the right answer is all of them. So BANS, BANS, B for back, A for arm, N for neck, and S for scalp. So those are all 4 have a worse prognosis. Okay, I'll let you guys cheat here. A child presents with these lesions, which she had from childhood, the most likely diagnosis. Well, if you have any different thoughts from C, go ahead and select other options. I think that opens more chances of discussion why this may not be the right answer. Okay. Okay. And why do we think this is C? And why not B? Who said that? Because this is in a child. The patient had those since childhood. Loge-Hanzuke you will see in adults, not in children or young adults. So more in middle-aged adults or late age adults. So that's the difference. And what about Addison disease? Why it cannot be Addison disease? Because this is in a child. Addison disease, adults, right? And McCune-Albright syndrome, cafe au lait spots, which you see more like a brown pigmentation on the chest or other parts of the body. It does not look like this kind of these freckles that you see on the lips and and in the oral cavity. These patients may also have freckles in the perioral, like around the lips on the skin. So that's very characteristic of this condition. The predominant growth pattern of nodular melanoma is Give me one more to move on. Yeah. Radial, vertical, radial and vertical. Okay. So the right answer is vertical, the predominant. So it may have a short kind of lateral span, but the predominant is vertical, where it grows into a mass like a nodule, and that's how it's easily, identified as something more concerning. When you see a mass, a tumor growing on the skin, that's melanoma. The other three variants, in those ones, the lateral is the radial, or the lateral phase is the most common. Okay. Which of the following has the highest rate of malignant transformation? And we see 3% for thick leukoplakia, 18 verruciform. The right answer is erythroleukoplakia. And the reason is, remember I said, if there's erythro in anything, erythroplakia, erythroleukoplakia, like the red component, that has a higher rate of malignant transformation. So the highest in erythroleukoplakia, followed then comes the verruciform leukoplakia, but the highest is erythro. Cytologic preparations are fixed in. Cytologic means ones from exfoliative cytology. Ethanol, Michel solution, formalin, all of the above. So we have a variety of answers here. Ethanol, the right answer is ethanol, 95% ethanol for cytology. Michel solution is used for immunofluorescence, so direct immunofluorescence when you want to send out specimen for lichen planus, pemphigoid, pemphigus, that's where you put the tissue in. Michel solution for frozens. Formalin is used for HND, like normal histology, hematoxylin and eosin HND preparation. So when you do surgical biopsies, you put the specimen in 10% formalin. And all of the above is wrong. 52-year-old presents with a white warty lesion on the palate. The most likely diagnosis is so verrucous carcinoma, xanthoma, condyloma, papilloma. The right answer is squamous papilloma. Condyloma, usually it does not, most of the time it does not look white. It looks like the color of the normal mucosa. It's more like a blunt, as if you punched a lesion, it looks like that. This is a well-defined white with finger-like projections, like warty, verrucous kind of presentation. Verruciform xanthoma does not look white. It looks more yellowish or orangish, yellowish orange. Not so commonly seen on the palate, but the most common lesion that has finger-like projections, you see on the palate or a soft palate especially, or on the uvula, that is a papilloma. So that's why papilloma is the right answer here. Okay, which of the following is true about verrucous carcinoma? We had this on the quiz today. It is a low grade, okay. It has a poor prognosis, it is most often. So the right answer is A. It is a low grade non-metastasizing form of squamous cell carcinoma. It does not have a poor prognosis. In comparison to oral squamous cell carcinomas, it has a good prognosis because if it does not metastasize as often as squamous cell carcinomas do, then it has a better prognosis. So entities, any malignancies that have a high potential for metastasis, those patients have poor prognosis. It is most often found on the palate, not most often. I think hard palate is the lowest one on the list where it can occur. So gingiva, vestibule, remember smokeless tobacco placement, where do you keep it? It's in the vestibule, in the buccal mucosa, tongue, those are the most common sites. What is the best indicator for squamous cell carcinoma? Staging, grading, both, none. And let's see the responses. 85 said staging, 2% grading, both. So the right answer is clinical staging. T and M staging, T for tumor size, N for nodal involvement, M for any metastasis, local or distant metastasis. So T and M is a clinical staging, and this is the best indicator to determine the prognosis of oral squamous cell carcinoma. Histologic grading is not consistently indicator for prognosis, but it may come into picture, say, when if a patient has any neural involvement. So if on the biopsy slide I see that the cancer cells are engulfing the nerves, they are in the blood vessels also, then my report will read that perineural and lymphovascular invasion is noted. So that's going to guide treatment. The patient may get radiation and chemo based on that thing. But otherwise, clinical staging is the best indicator for prognosis of those patients. And that guides the treatment of such patients. Okay. What differentiates a carcinoma from carcinoma in situ? The right answer is A and C, invasion to the connective tissue. So that is how carcinoma in situ is different from the cancer. Then because this is not cancer, it does not have the potential to metastasize unless it it breaches the basement membrane and starts invading the connective tissue. It cannot metastasize. The diagnosis of this lesion may include all of the following except SCC, squamous cell carcinoma. May include all of the following except this. So we have again a variety of answers. Does this look concerning to you? Look at all the options. Squamous cell carcinoma, cancer; verrucous carcinoma, cancer; snuff dippers cancer, cancer. Which is the exception here? So if I'm giving you 3 options of cancer and I throw in a benign lesion, then you know what is the exception here. But otherwise, okay, let's get back to the clinical presentation. What does this look benign or malignant? Are we all up for malignant? If anyone has benign on the mind, then we can definitely discuss why malignant. It looks bad, verrucous warty, but you see the patient has other white lesions, extensive lesions on the dorsum of the tongue too, right? It's not a localized lesion how we see a papilloma, like a well demarcated cutie pie, white with, finger-like projections. This looks completely different from that. So that's why it is cancer. And if you pay close attention, 3 of the options are cancers and there's just 1 benign lesion. So you know what is the answer. 55-year-old female presented with these lesions that you see in the mouth, those white ones, and then some lesions on the skin. What is the most likely diagnosis here? HBID, hereditary benign intraepithelial disc keratosis. This is one of the developmental conditions in which patients have white lesions in the mouth. Kaposi sarcoma, lichen planus, HBID, Addison disease. So the right answer is lichen planus. But how many of you said lichen planus? And why do you think so? And that's the right answer, but I want others to know that. Skin, okay. Is that the only reason? So she said the patient has lesions both in the mouth and the skin, but that's not the only criteria for it to be lichen planus. Look at the oral lesions. They look like white lines that you see on the buccal mucosa, white, interlacy, interconnecting, lines. Those are called Wickham striae that you see in lichen planus. I don't expect you to identify the condition looking at the skin lesions alone, but this is just to let you know that the patient has skin lesions, they have oral lesions. But look at the oral lesions. They look like white, interlacing kind of connecting lines. That is called Wickham striae, and these are very specific for and diagnostic for oral lichen planus. That's why that is the right answer. Kaposi sarcoma is a malignancy. So it arises most commonly seen in people who have AIDS. They can have skin lesions that look somewhat like this, but more like purple kind of papules or nodules, but the skin lesions don't look like Wickham's tribe. It's a cancer, so they will not look so, benign looking. HBID, hereditary benign intraepithelial disc keratosis. So the patient has lesions in the mouth, but they are white in color, and the patients have eye involvement also. They have gelatinous plaques around the conjunctiva. Addison's disease. Addison's disease is something in which the patients will have unexplained origin or development of multiple pigmented kind of melanin kind brown pigmentation in the mouth, but this is white. So that's why lichen planus is the right answer. Okay. And I will give you the, did I activate it? Most common site for oral melanoma. So before you answer, even in the exam, quizzes, test, always read the question carefully. What is being asked? And the right answer is two of the above, and they are the maxillary gingiva and the hard palate. Oral melanoma, high predilection for the palate, for the maxillary gingiva, maxillary alveolar mucosa, those are the high side. A farmer presents with a white lesion on the lower lip. What is the most likely diagnosis? So the clue is farmer. Cheilitis, leukoplakia, frictional keratosis. As I said, the clue is the farmer. So this is a patient who spends more time out in the sun. So anything related to sun in the differentials in the list of options. So actinic sun exposure, actinic cheilitis. So this is actinic cheilitis. Leukoplakia, this is still not leukoplakia, but many of these patients who have actinic cheilitis, over time, they may develop thick white areas that are leukoplakias. But right now, this is not leukoplakia. Lish nodules are characteristic of Lish nodules are characteristic of NF type 1, neurofibromatosis type 1. So Lish nodules are those brown pigmented, dot-like lesions that you see in the eyes of these patients. So what else do you see in NF type 1? Multiple neurofibromas in the mouth. Sturge-Weber syndrome. Remember anything about this? Portwine stain, which is usually unilateral. The patients have other brain, benign brain tumors, most commonly angiomas. Radiographic imaging, you will see tram-like calcifications in the skull. And what was meant to be multiple mucosal neuromas in the mouth. So if you see two raised lesions, especially in the child at the corners of the mouth in the commissure area, This could be diagnostic of men 2B. Okay. And let's move on. So those are mucosal neuromas in the mouth. We have 4 minutes left. Okay. The most likely diagnosis for this presentation is so the right answer is nicotine stomatitis. So what you see in the mouth is you see multiple papules, multiple separate papules, but in the middle, in the center of the papule, you see a red dot. So those papules are the inflamed minor salivary glands. They are inflamed secondary to the heat that is generated from the smoking, from smoking cigarettes or cigars or pipes. And that red dot in the middle is the opening of that minor inflamed salivary gland. So this is reactive to smoking. 40-year-old presents with these bilateral lesions which disappear upon stretching. What are they most likely to be? So you see this white lesion here in the cheek. And I tell you, when I stretch the cheek, I don't see it. The right answer is leukoedema. So the clue for clinical diagnosis of leukoedema, that you have to stretch the cheek to see if it goes away or if it if it minimizes the white thing, the gray white thing that you see in the mouth, if it is reduced on stretching the cheek. That is the main clue for diagnosis of leukoedema. You don't have to do any biopsy, no treatment is needed. Tobacco pouch keratosis, white sponge nevus. So white sponge nevus, these are developmental condition. It's a developmental condition. Patient will have white lesions from either birth or early childhood, and they don't go away on stretching the cheek. The only thing that I know of goes away and looks white in color is leukoedema. Okay. I think that's an easy one. We can do that. 24-year-old presents with these asymptomatic lesions. These are representative of so the right answer is geographic tongue. This is geographic tongue, erythematous lesions with white kind of serpentinous borders. That's very characteristic of geographic tongue. We can do one more and then I will give you the PowerPoint. I'll send you the PowerPoint of all these questions. You can go over those. A 10-year-old presents with these lesions. His mother reported the other son also has similar lesions, the most likely diagnosis. So the clue is that this is a familial, it has a familial tendency. So it has to be something either developmental or, So you see multiple papules on the lips here. And this is Heck disease. Multiple papillomas, I don't see a reason why a kid will have multiple papillomas without any reason, right? Or multiple condylomas. So if you find a condyloma in a child's mouth, that is a sign of sexual abuse and you should report it to the child and welfare services. And the first one, florid papillomatosis, again, I have not even taught you that, I think. But papillomatosis means having multiple papillomas, papillary lesions in the mouth. Why would a child have those? We will end here. So we will meet next week in the testing center for the midterm exam at which will start at 9 o'clock. Do not use any short forms, any acronyms. You have to write the full form. Okay, don't write for pyogenic granuloma, don't write PG, don't write PGCG, because you will get partial credit on that. I will post another CPC, so you can practice on that. If you have any questions, you are looking for answers, you can send me an email. We can work